of financial burdens. And so we wanted to be able to share some information with the community to let you know both about the science and biology, but also just some of the resources that are now available for folks who are trying to build their families now or in the future, with the goal being that like the UCSF family now has more tools for this part of life that is such a priority for so many people. And by that, I mean family. I'm joined today by Dr. Lauri Pasch. She's a research-trained PhD psychologist right here with me, who is incredible, has more leadership roles than I could list, but has been a huge asset in the reproductive psychology field, specializes in many of the psychological domains related to feelings and thoughts around fertility issues and legacy and family creation. So she sees patients both clinically and does a lot of research as well. And so she's really eminent in the field of reproductive psychology. So that timeline for today is I'll give a brief presentation about some of the medicine, the clinical work, the biology around fertility and infertility issues. Lauri can discuss some of the things that are top of mind for her. We are joined by some of our management, including Mark Widows, who runs the kind of finance side of the Center for Reproductive Health, where fertility medicine lives at UCSF, physically in Mission Bay. There he is now. And so he'll be available to also answer any questions people have about some of the new benefits and other information that may be directly applicable to folks here today. So super casual, meant to be a resource for community, and please feel free to chime in, ask questions by the chat. This is really intended not for me or Lauri at all, but for you guys. So please lean on us and ask what's on your mind, and hopefully we can share some helpful information with you today. So I'm going to go ahead and share my screen. If you hear screaming in the background, that is a consequence of my own fertility. I hope that the children aren't too crazy here, but we'll see. Okay, so let's get started. Like I said, I'm Eleni Jaswa. Thanks so much for joining us today and for your interest in our life's work. These are just a few recent headlines lifting up the fact that in medicine, fertility issues are prominent, right? So this isn't just for doctors who notoriously are old women by the time we start our families because of prolonged training. This applies to really across the board. You've got your nursing practitioners, your nurses, medical assistants, administrative staff. Fertility issues are top of mind, especially in coastal towns like San Francisco, where we're delaying childbearing at large. And so it's a real need and an under-met need, especially given the very obstructive expense associated with many fertility treatments. So this is really exciting to me. This is hot off the press, just published this year, a new definition of infertility for like maybe the first time in a century, from our society, the American Society of Reproductive Medicine. Think of it like the AMA, American Medical Association of Reproductive Medicine. And the intention in updating this definition was recognizing that the old way of thinking about infertility was pretty exclusive. And the goal here is to be as inclusive as possible to help as many people as possible, because family doesn't just apply to a man and a woman trying to have sex. So infertility is a disease, condition, or status which can be characterized by any of these following things. Number one is not being able to get pregnant based on something related to medical history, sexual history, reproductive history, age, which we see a lot in San Francisco, physical findings, any testing or combination of these factors. Number two, the need for a medical intervention, which might include using gametes like donor sperm, donor egg, or donor embryos. So understanding it takes a village in order to achieve a successful pregnancy, which can be as a single woman, as a single man, as a partnered couple of 2 men, 2 women. This would also qualify as an infertility. And lastly, infertility can be patients having regular unprotected sex, without getting pregnant, and no kind of already known feature or risk factor for not getting pregnant. And as far as timelines go, if we're talking about a man and a woman having regular unprotected sex where the woman is less than 35, it's okay to try on their own for up to 12 months, after which point they should be evaluated. Now, if the woman is older, and usually 35 is that like magic geriatric misogynistic termed number, after 35, you should really, a workup is warranted more quickly, after 6 months of trying without a conception. Importantly, we'd like to highlight that nothing in this definition should be used to like deny treatment or delay any type of services, especially on the basis of relationship status, single, partner, otherwise, or sexual orientation. So I think that's a huge step forward as a society for how we think about fertility medicine and infertility issues. When we are talking about like some of the more classic epidemiology, when you're thinking about a heterosexual couple, infertility affects 1 in 6 of those couples. Obviously, if there's no sperm or no eggs in the relationship, it's a different story. That would be more like 100% of couples. They're on average regularly heterosexual couples having regular unprotected intercourse, the majority of them will get pregnant within 12 months, 85 to 90%. So in that situation, we're saying the prevalence of infertility is probably 10 to 15%, which corresponds to that 1 in 6 couples. After 12 months of trying without getting pregnant, a heterosexual couple is not sterile necessarily. 5% will get pregnant in that second year of trying, but those are pretty low chances on a monthly basis. And especially if you want multiple children and the female partner's getting older, time is often of the essence. So it makes sense to do a workup before trying for 2 years. And the likelihood of getting pregnant varies with age dramatically. That's the biggest driver out of anything, as well as how long people have been trying without getting pregnant. Obviously, folks who've been trying for 6 years without a pregnancy we think about them differently from people who've been trying for 6 months, suggesting there might be something more severe going on. This is a 1956 JAMA study watching a population, I think, of Hutterites, which is a kind of Amish-like community for, hopefully that's not offensive to anybody, but basically a traditional community that doesn't use contraception. And you can kind of see the natural history of fertility in a community setting. And you see of those couples, there's this diminishing returns concept, which we'll come back to again and again with any infertility treatment. It's part of the biology. Most couples, more than 50%, will get pregnant within those first 3 months of trying, almost 75% within the first 6 months. And then you see the rates per month kind of level off, where 85% have conceived by a year and 93% by 2 years. And so most people actually get pregnant pretty quickly, and the longer you try, there's diminishing returns with any given approach, whether it's natural conception, IUI, or IVF. So what causes infertility? When you actually dig deep on how babies are made, the biology is like magnificent and mind-blowing. It's incredible that we're all sitting around because there's this complex orchestration of so many biologic pathways and signals and cascades. That is amazing with the number of things that can go wrong, how often it goes right. However, for those folks who aren't getting pregnant on their own, there may be an issue related to woman's not getting her period. She's just not releasing an egg regularly. There could be issues that are anatomic. The fallopian tubes, for example, are scarred related to a prior infection or surgery or something like endometriosis. There takes, sperm as well, and there might be sperm issues. Age, there could still be eggs, but the quality of those eggs is so poor, it's hard to make a healthy baby. And then there's residual category of up to 30% of folks we see that you've got sperm, you've got eggs, the anatomy looks fine, we don't really know. And that's just a shortcoming of modern medicine and what we know in this day and age, that we don't always have a name for why somebody might not be getting pregnant. Again, this is obviously in the context of a heterosexual couple, but we acknowledge that it does take two to tango. Male and female factors often contribute to for at least 40% of causes. The breakdown of these different sources of infertility will depend on your population. So even if you work at Mission Bay, UCSF, versus go across town to San Francisco General Hospital, you're going to see a totally different distribution of causes of infertility across populations. So this is really like socio-demographically dependent. A little like biology primer just to remember what's going on in pregnancy. Well, here are the steps that are required. You got to ovulate, release an egg. That egg has to be picked up by a fallopian tube. A sperm has to fertilize it in the tube. That fertilized egg divides in subsequent cell divisions until it makes it to the uterus, where it implants. And so this is this all from ovulation to implantation. Usually that's about a week-long trip to the uterus, and then 1 week later you can find out if you're pregnant or not, as that implanting embryo starts to signal with HCG that reaches the bloodstream. So the requirements for getting pregnant in your own body are ovulation, fertilization, and implantation. A basic fertility workup for a heterosexual couple with otherwise no obvious reasoning for not getting pregnant includes looking at the basic ingredients. Are there eggs? Are there sperm? Are the tubes open? And what's your kind of like ovarian reserve status at this point in your life? And so what are the tests that we do to check for those really basic cookie cutter ingredients? Eggs is, we just ask you, are you getting a regular period once a month? The only way that that is possible, that kind of orchestrated sequence of cyclic bleeding, is via ovulation. So if you're getting your period more or less regularly, you have eggs. There's different imaging technologies to look at the tubes, and the sperm testing is done through a semen analysis. When we talk about ovarian reserve testing, we're primarily talking about a blood test. Some people may be aware of this AMH, anti-Müllerian hormone, a hormone produced by the cells that support the eggs. This corresponds to the number of underlying eggs that a woman has remaining, as well as an ultrasound finding counting up the antral follicles in her eggs. We talked a little bit about this before, but just to highlight that we should medically offer an evaluation to couples that pretty quickly. If the female partner in a heterosexual situation is over 35 by 6 months of trying, you should really get checked out. If the female is older, like over 40, more immediately. Now, obviously, if it's a single female or a single male or a gay or lesbian couple, come right away, because you're not obviously getting pregnant without the other gamete. Okay, so this is just a chart to show like the life cycle of eggs in a woman. The bottom line is women are born with every egg we'll ever have. We peak when our moms are pregnant in their second trimester with us. It's like a babushka doll. So like your mom had you and your eggs for their future grandchildren in their body all at the same time, which is a little bit mind-blowing. But at 20 weeks of her pregnancy, that's when you have the most eggs ever. And then this declines from the fetal life to birth to puberty. And by menopause, that is when a woman runs out, hits a critical threshold of eggs, and the ovary stops working or fails. That's menopause, which on average is 51. I think there's some animations in here that I need to get rid of, but just to give you ballpark numbers, peak number of eggs is 6 to 7 million eggs in a 20-week fetus. By the time that female baby is born, she's got more like 600,000 or 700,000 eggs. By the time she goes through puberty and starts releasing eggs, there's 300,000. Over the course of an average female life, 400 to 500 eggs will be ovulated. And then at age 51, on average, is when they'll run out of eggs and no longer can become pregnant. Okay, so I mentioned age is like the number one thing for fertility-related issues. And what you can see here is this is, again, a spontaneously conceiving population. but the impact of maternal age on the x-axis on fertility, so natural conceptions, you can see it dramatically fall. I think the story we tell a lot of women, or at least through our medical terminology, is like, you're sitting pretty till you're 35 and then you like fall off this geriatric cliff and should be a grandma. That's not exactly what's happening. There's no cliff, but you do see this accelerating decline in fertility with increasing age. By the time a woman is 45, pregnancy is really, really rare. Even with IVF, the success rates at 45 and older are going to be certainly less than 5% per cycle. On the other hand, so the fertility declines with age, primarily related to egg quality. Think of it, you're born with the egg ages like any other cell in the body. So the quality declines. And egg quality is, as a consequence, an older female is both, number one, less likely to become pregnant, but number two, more likely to suffer a miscarriage or spontaneous abortion. These are both a function of reduction in egg quality. And by egg quality related to age, we're talking about DNA content, the ability to divide into cells with the right amount of DNA needed to make a healthy baby. So you can see with this study, it suggested that women 45 and older, even if you do get pregnant, which is less than 10 per 1,000 married women, over 90% of those pregnancies will result in miscarriage related to egg quality. On the right-hand panel, we see this data paralleled in an IVF setting. So in IVF, what the authors here looked at was the age of the female. They biopsied thousands of embryos made through IVF, and they looked at what percent of these embryos are abnormal or aneuploid, the wrong amount of chromosomes. And you can see the same pattern of this nadir of peak egg quality in the late 20s, and then an increasing rate of aneuploidy with increasing female age up to almost 90% by age 44, 45. So what we see in nature is also what we see in the lab. This is our bottleneck of fertility medicine in this day and age is egg quality related to age. So, okay, that's a little bit, that's our discussion of fertility basics, workup of infertility in a heterosexual couple. Let's shift gears now and talk about treatment options. So this is obviously dependent on your diagnosis and specific situation, but at the end of the day, there aren't that many things we can do to help people get pregnant. There's a kind of, I divide it for my patients into two buckets, your low tech and then your high tech. So low tech, we're talking about using medications to either help you ovulate in the first place in the setting of a woman not ovulating, like ovulation induction, or medications to try to just spit out more eggs with the hope that one of them will be normal, something called superovulation, where people still have sex in their beds. The other low-tech treatment option that a lot of people will think about is intrauterine insemination, or IUI. This is where we often will couple some medications to serve as an ovulation booster with an insemination, where sperm from a donor or a partner or whomever is concentrated and it placed in a tiny catheter, which is used to bypass the vagina, cervix, and uterus, depositing the sperm at the right place and time, allowing that sperm to skip 95% of the 100-mile marathon equivalent of its journey when deposited in a vagina, having to get to the egg, and just kind of flooding the system that way. That's your low-tech treatment, pills and or insemination. High tech, and I think most people have heard about this, is in vitro fertilization, which is the single kind of most powerful or most efficient tool available for fertility. Before somebody gets to the treatment domain, if they're just thinking of like, I'm pulling the goalie, I want a little information about how can I be most efficient with my time and trying to make my family. Fertility, natural fertility is all about timing. So in the whole menstrual cycle, which on average is 28 days, about 5 days of that you actually are considered a fertile window. That means an act of unprotected sex during those 5 days might result in a pregnancy. Sex during any of the other 23 out of 28 days is totally just for fun, non-reproductive. And so how does that relate to ovulation, and how might you track that? Well, this graph on the right shows ovulation being day 0. And based on age, you see per day specific probability of pregnancy. So what we notice is, first of all, in general, the fertile window opens about 5 days leading up to ovulation and closes on the day of ovulation itself. If you have sex the day after you've ovulated, it's too late. And so really your optimal, and study again has shown this, but your best chances for any single act of unprotected sex for getting pregnant are in the 3 days leading up to ovulation. And so how can you find that you're in that window? Some people will use urinary luteinizing hormone or LH kits called ovulation predictor kits. These show you when your window starts to open and then when you've actually had your LH surge, which is followed by ovulation, typically a day later. People will just follow their cycles and use a calendar method based on an app. Some people use basal body temperature or charting. Some people are quite aware of their changes in cervical mucus. As that thins, that tends to correspond to the opening of your fertile window. People ask about, does it matter like if we have sex every day or every other day? The short answer is, in general, every other day is fine. Every day, if you can manage, is slightly better. Position doesn't matter. There's no like need to throw legs in the air for 15 minutes or change your approach. It's just once the sperm is in the vagina, you're pretty good to go. I think this is I'm coming to the conclusion of my slides here, but I just wanted to also mention for a lot of UCSF community, faculty, staff, trainees are thinking about family a lot, but not ready now. That being said, they're aware of kind of a female getting older and what the implications are. And if you kind of cycle it forward and you say, oh, I'm 35 now, I want a few kids, I'm not going to start for another couple of years, you'd be looking at what, like having a baby at 37, 38, and then put 2 years between each baby is kind of the fastest turnaround. So if you're counting on having a baby at 38, 40, 42, that's where people tend to run into trouble. And so there are these options for fertility preservation. That means basically the female going through IVF stimulation, getting the eggs out of her body, and then either freezing them right there as eggs or as embryos following insemination with the sperm of their choice, whether it's in a partnership or a donor type situation. The trade-offs between freezing eggs versus embryos, I would say the main advantage of eggs is just the option value. God forbid your relationship fails, somebody gets hit by a bus, things change that are unpredictable in the future. Eggs, you aren't locked in genetically to the father. So that's the most option value. And if money is specifically tight, it's less expensive a treatment that's upfront. Ultimately, if you come back to use these eggs, you'll incur the same costs that would be associated with making embryos. On the other hand, if you're in a situation where you can make embryos, I think the main advantage is that you can get more information. With eggs, you just know mature, not mature. You don't really know quality, how many will fertilize, how many of those will divide, how many will make it to blastocyst stage, what has the right amount of DNA. With embryos, you can actually test them through a process called pre-implantation genetic testing, or PGT, which allows you to get more information on what you actually have frozen and what your chances are of having a baby or more than one baby in that batch. Also upfront, because there are fewer manipulations, if you freeze your eggs and then use them, you'll have to thaw them, inseminate them, grow them, potentially refreeze them. There's an additional step. So embryos will always be kind of like slightly better, but I will say egg freezing technology has come so far that this shouldn't be a huge driver for most women under 40 or so in determining a choice. Let me see, is this it? Okay, yeah. So last slide, this is just a model that's a counseling tool we'll use in a situation of a woman freezing her eggs to give a sense of what are my chances. This is super hand wavy because each step is a biological process that we see a normal distribution of outcomes. People can do better or worse at each step of the way, so there's a lot of uncertainty. But to have some ballpark idea, what you see here on the x-axis is the number of mature eggs a female has frozen. On the y-axis, the chances of having at least one baby in this batch of eggs. And then these rainbow-colored lines indicate the female age. And so it tells you a few things right up front. 10 eggs at age 35 versus 10 eggs at age 44 are night and day. you can see the quality impact on your chances of having at least one baby. It also tells you, you know, there's really no guarantee. Don't change your whole life around this, counting on a baby. There's never a guarantee that there's a healthy baby or family in here. But it can give you a sense of, if you're 38 and you froze 10 eggs, you're looking at a 45% chance of having at least one baby in here. So people use this to get a sense of, is it worth it for me? How many cycles do I want to do? What are my goals? And there's so many individual considerations that go into treatment, that it's really a case-by-case scenario, but it's nice just to have some ballpark sense of what this technology can and can't offer. So with that, I'm just going to put up some resources here. We have our Center for Reproductive Health. Again, we're located at 499 Illinois Street, right next door to the Chase Center, where the Warriors play. This is our phone number. SART is the Society for Assisted Reproductive Technology. It's like a centralized reporting system where all IVF clinics across America pool their data. So you can see clinic-specific data, you can see other resources in your community, and that's a good place to find different clinics as well. And then lastly, there's I believe she's still at UCSF, Sue Forstat, who's a manager in some of the benefits programs, and this is her direct contact information if you have any questions related to some of the newly rolled out benefits for UCSF affiliates. Yeah, and with that,
Dr. Jaswa, I was wondering if you could speak for a moment about how we are able to support people who have had one or more miscarriages in the past, because somebody has put a question about that into the chat. And it would be awesome if you could just add a little bit about what fertility treatment can do for those people.
That's a great question. Thanks for highlighting that. I haven't been monitoring the chat, so I really appreciate that, Lauri. And so, yeah, you're right. This isn't, our area of expertise doesn't just cover, we can't get pregnant. Recurrent miscarriages or miscarriages are also bread and butter reproductive medicine, and we provide services for that. So depending on the specific scenario, certainly 2 or more losses, there are certain tests that are available to see if there's anything going on that might predispose to a subsequent loss. We'll always look at what information do we have around the losses that somebody has suffered, if there's any clues there, trying to do our best to individualize a treatment program to do whatever we can to reduce the chance of a subsequent miscarriage and get a healthy baby in that family's arms as quickly, cheaply, and effectively as possible. We also acknowledge that recurrent pregnancy loss is like a very PTSD-inducing, distressing situation. Just like infertility, where I think we acknowledged many years ago that a lot of women say they'd rather have a cancer diagnosis than infertility. Recurrent pregnancy loss, I think we're starting to acknowledge the extreme psychological burden this places on individuals and families. And that's where our colleagues like Dr. Pasch, Dr. Holly, and some of our affiliates across the OB division are really, really helpful in providing, I think, support and resources for the whole human beyond just the medical tests, research studies we have available. Does that answer the question? Let's see what else we have going on in the
well, I mean, it might be useful for the person who is asking to tell them a little bit about how it can be that repetitive loss patients can get help from IVF.
Oh, sure. So the way I personally think about IVF in a situation of repetitive loss is especially for those women who are having losses that are aneuploid, abnormal embryos. So if you have testing of the miscarriage tissue and it says there was a trisomy, there was a missing chromosome, this is the cause of the loss, that's where IVF with genetic testing might really be helpful, because there's this idea out there that some women are just like, not like, don't discriminate, like just very welcoming to any embryo, and so like super fertile in that sense, and anything can implant, and then only do they have a delayed recognition that that conception unfortunately isn't going to be a healthy baby. So in those situations where somebody's having a lot of abnormal losses, being able to actually to pre-screen the embryos via IVF and a biopsy and genetic testing can be really meaningful in reducing the risk of a subsequent miscarriage. Really good question. There's a question here in the Q&A, Lauri. I'm not sure if you see it, if you want to read it aloud and address it.
Oh, yeah. So someone said, can you recommend a psychologist to talk about recurrent miscarriages? And now it is too late, an issue of legacy and grief. Yes. Yeah, definitely. So I put into the chat already, if I hope you guys can see it, our pregnancy loss resource list. And is it coming up? Or no, I answered it in the Q of A. So if you click on answered questions, I added in all of our long resource list about pregnancy loss, in addition to a webinar that was done by one of the OBGYNs in our department, plus Dr. Huddleston, who is Dr. Jaswa's colleague, as well as the social worker in Melissa Whippo. She's not with us in our program anymore, but they talk about a lot of a drill down on pregnancy loss. And so you'll see resources for finding a therapist there. There's a really great book called Surviving the Unimaginable, and I'll put that into the Q&A too. That could be a good source of reading support. But in fact, the author of that book, Pasquale Vermont, is a great therapist for the person who was just asking about that. So really important. I would love to talk for just a minute. I'm one of the psychologists in the Center for Reproductive Health, and I believe our other psychologist is also here, but I'm not sure if she is if she's in the panel, so she might not be able to show her, which is fine. I wanted to just talk about a few things, and one of them is that as Dr. Jaswa said, fertility treatment, it's just going through infertility, going through the process of trying to conceive, even if you're not coming in because of infertility, it has a lot of stresses associated with it. There's stresses associated with the cost, with the pain that can be associated with injections, stresses associated with how much it interrupts your life. So in all in the context of the big picture of not being sure if it's going to be successful. So we've done a little bit of research at UCSF and come to the conclusion that going through fertility treatment is actually one of the most stressful things that a person can do in terms of compared to other procedures that are offered at UCSF Medical Center. And so that's why we have an in-house program to provide support. Really unusual. Most medical most providers at UCSF don't have a therapist that works right in their clinic, but we do, and that's the reason. It's because going through this process can be really stressful. That's really important. I know Dr. Holly wants me to mention as well is that a lot of times people think that stress that they're going through is going to inhibit their chances of being successful. And we just need to know that we don't really think there's any good evidence for that at all. And it's much more important to think about what we can do to manage stress than to be thinking that stress is causing you not to have success. We did some research on that at UCSF as well. We found that some women started their IVF cycle really quite distressed. So feeling down and pessimistic that it was just hard to imagine them even being able to get through their cycle. And then there are other people that are just kind of really not on same results. Okay, so people who are really distressed get pregnant and don't get pregnant. People who are really optimistic and positive and don't get pregnant. It's really important not to stress about your stress. And then we have a lot of tools that we refer our patients to. We provide some direct support. We connect people with support groups, with therapists in the community, with regard to fertility treatment and with regard to pregnancy loss. And we support the needs of all types of different circumstances that bring people into fertility treatment. As Dr. Jaswa said, it is not all about the man and the woman who conceive at home. We are providing support to family building of all types, and we have support in place for families of all types as well. Another thing that we do is for people who are using gamete donation to conceive, and that might be egg donation or sperm donation, and also for people who are going to be using a gestational carrier for their family building education about the long-term issues associated with those decisions. So that's right here in our clinic, ready to help you. The only thing that I worry about is people who don't come in or who drop out because they're afraid or they have questions that they don't feel like they can ask, or they feel like it was too stressful. So we don't want that. Questions, if you have concerns, we want to help. And in fact, you can just really reach out to our clinic. You can actually directly send me an email if you want and just say, hey, I'm thinking about this, but I don't know if I'm the person, if I'm in the right place to get started. So we're here to support you. And there's all types of individual stories of how people come to fertility treatment. Some people are not sure about their relationship. Some people are not sure if they're ready. Some people are concerned that their family building plan is not going to be supported. We just want to hear from you and provide you with some support. So I think that's it. I would love to know if anybody who participated in this today has any questions, because we can stop the recording and just open it up for that, for a little bit of privacy. But we will use this recording maybe to let other people know about our services. So maybe we could stop the recording and